The model, something really unique that it's very difficult to do without an agent-based model, is we have a sexual network. So we have mother-to-child transmission as well as sexual transmission, and we actually represent each and every partnership and how those partnerships form and dissolve, and we categorize them into different partnership types, ranging from marital to sex work, and then in between various informal partnerships. We have the progression of HIV disease. So this is very, very important for this particular analysis. So if somebody becomes HIV positive, their CD4 count will gradually decline, which gives them greater and greater risk of morbidities like tuberculosis, and eventually, other AIDS-defining illnesses. And if somebody initiates treatment, their CD4 count can reconstitute. And something fairly important in our analysis here was that people who interrupt HIV treatment or people who become HIV infected, the amount of time that they can survive off treatment and maintain the virus and latency is age dependent in this model. So in general, people who are quite young, in their late teens or 20s, kind of at the peak of the prime of life, if they become HIV infected, they can survive for 10 or 12 years, until they begin to develop AIDS. Whereas people who are older in life and either acquire HIV or interrupt treatment may only have 1 or 2 years in which they can maintain viral latency, because in our older age, we have no thymus anymore. It's very hard for the body to replenish T cells that this virus destroys. And then finally, we have a care and a prevention continuum. So we model HIV diagnosis, different forms of testing to get into care, whether it be routine testing, provider-initiated or client-initiated, whether it be antenatal screening for HIV, which is how many women become diagnosed. The children of pregnant women who are HIV positive are also screened using a special test, because standard testing is confounded by the presence of the mother's antibodies. And then finally, if somebody develops symptoms that may be indicative of progression of HIV disease, they'll be tested as well. So people who really wait a long time to get into care could still be picked up later in life, although, of course, survival is not as good if people already have their immune system quite depleted before they initiate treatment. So that's just a snapshot of this relatively complicated model. There's a lot about it online. And I hope you'll remember this if you, in the future, need a collaborator on an HIV project that requires this type of modeling. So in the midst of these disruptions, we were lucky. We spent a couple of days kind of shut in a room with the Ministry of Health to really pick their brains about what's going on and how these disruptions might play out. And so we did this in a very collaborative way. We listened to them talk qualitatively about what was happening, some of the things that I mentioned earlier with the electronic health system shutting down and what that meant for defaulter tracing, for appointment systems, for prescribing the correct medications, the sample couriers, all of this. And then from that qualitative discussion, we categorized what the different effects of the disruptions might be, and we started putting numbers on the board. And we iterated those numbers until those in the room felt that it really represented what they thought might be happening. So it was a really powerful partnership because we were doing this completely in the absence of data. The very data systems that we would normally rely on had completely come down. And so we were really relying on these people and their understanding of their own health system to shape these assumptions. So our overall aim here was to estimate the impact of PEPFAR interruptions in Zambia with these scenarios informed by the Ministry of Health. The outcomes that they were most interested in were the number of additional HIV infections, the number of HIV-related deaths, and the prevalence of HIV if a disruption as severe as what was happening then were to continue for different amounts of time. And then these on the right are the assumptions that we developed, again, using that collaborative whiteboard approach. So because, as I mentioned, those of you who came in a little late may have missed, the northern part of Zambia was especially vulnerable to these disruptions. So overall, Zambia had 85% of its funding for HIV care through PEPFAR. And in the northern part of Zambia, USAID actually was providing frontline implementation. So nurses, doctors were USAID employees and were just overnight told to go home. And then in all facilities throughout Zambia, people like data clerks might have been USAID or CDC employees. So many of these clinics had implemented fully digital workflows. There was no paper. And those people were told, go home tomorrow. If you have a laptop, shut it down, put it in the USAID office, and we're going to lock the door. Or if you have a desktop, there wasn't time to tell someone the password, or how to use it. So that was the circumstance. So based on that qualitative circumstance, we arrived at this number that 40% of new and returning clients in the 5 provinces in northern Zambia, where USAID was the primary implementer, would lose access to treatment. And then we additionally assumed that treatment attrition would rise to about 20% per year. And that was based off of old studies. So in the mid-2010s, that was approximately the rate of treatment attrition in Zambia. And these systems, appointment systems, defaulter tracing, these were put in specifically to address this problem. So we envisaged basically going backward a decade in terms of the care continuum. We knew that PrEP access was almost completely reduced. The only PrEP available was for pregnant and breastfeeding women, and the male circumcision program completely stopped. And then we looked at different durations of this interruption, from 3 months, 1 year, 3 years, to unabated. And sorry, I think that should be 4 years, because our presidential terms are 4 years in America. That's a typo. So here is what we found. We found that unmitigated disruptions to PEPFAR, so if what was happening in January and February were to just continue happening, that there would be huge increases in HIV-related deaths. And as you might expect, the more you curtail the length of the disruptions, the more you can prevent those harms. And so here, the purple line, I know it's a little hard to see here, this is going from, this is 2020, and then this is the disruption in 2025, and this is going all the way out to 2060, so looking far into the future. The purple line is a very unlikely scenario, but we wanted to play it out anyway, of what would happen if that 85% budget reduction and recall of staff were unmitigated for this entire period of time. And what you basically see is a gigantic epidemic resurgence. So we're back to square one with HIV. And then we imagined if this disruption were reversed within different lengths of time. So this green line is if it were reversed in 4 years. The red line is 1 year, and the yellow line is 3 months. And the only difference between these graphs is what's happening with women and what's happening with men. So we see a larger resurgence actually in women in terms of annual HIV-related deaths, and that's because the prevalence of HIV is higher in women, and they were accessing care, so they stand to lose the most, right, if care is pulled out. We found that from this unabated disruption, the number of additional deaths over this entire time period would actually be more than 1 million. It would be 1.6 million additional deaths. And that's an increase of 427% compared to if there were no disruption. The green line here would be the rest of the Trump presidential term, maintaining this disruption. And there we found almost a doubling, an 89% increase in deaths, with a total incremental death count of 330,000. And then even from this 1 year disruption, we found a 31% increase in deaths, with that count being 115,000. And also, you're probably already seeing this, but you can look at the kinetics of this as well, where if the disruption could be limited to just 3 or 4 months, basically mortality will come back down to baseline. But if the disruption is allowed to persist for a year or more, you still don't see a return to baseline until like the late 2040s. So you'll see this, permanent loss of progress in controlling HIV mortality. This is sort of the same story, but in terms of HIV incidence. And so in terms of incidence, incidence is the rate of new infections per HIV negative population. So how quickly are people who are negative acquiring HIV? And you see, first of all, compared to the last slide, that the resurgence happens a lot faster. And the reason for that is if you take different forms of prevention away from people, so you take away PrEP, you take away treatment as prevention, meaning people who were on treatment go off and now they're able to transmit to other people. Even tomorrow, you'll see an increase in infections. Whereas deaths, like I told you before, some people can go on for a decade, before they progress to AIDS. So with incidence, we see this resurgence very, very quickly. We see actually, again, we have women and men. This is going to 2060. And in this unabated scenario, this worst case scenario, that what happened in January keeps happening indefinitely, we would have seen an almost 800% increase in new HIV infections. It rises very, very quickly, and it would have been about 3.3 million additional HIV infections. So we actually lose a lot more ground on prevention even than we do on mortality. With the rest of the Trump presidential term, we see a 132% increase, an additional more than 500,000 HIV infections over this period. And with a 1-year disruption, we see a 47%, so almost 50% increase. And we can look again at the kinetics of this process. So we already saw that the resurgence, it happens very quickly. And the other thing with prevention is once you lose a lot of ground, even if you lose that ground relatively briefly, that lost ground is still there for years to come. So even if it's a few-month disruption, which we now know is kind of close to what might be happening, some of these gaps are starting to get filled, you still will see a noticeable increase in incidence, at least through the 2030s. And you can see the same in men. So, I think what this is telling us is that containing HIV mortality, if there's a brief disruption, we can quickly gain that ground back. But containing HIV incidence, keeping the epidemic from spreading to other people, that's a very fragile thing, and we have to keep that promise consistently. If we lose ground even briefly, we kind of lose that ground for a long period of time. Please do interrupt me, because I'm sure this is very upsetting to a lot of people. You probably have a lot of questions.
It's very scary.
It is, right? It's controlling transmissible disease is like trying to put a cap on an exponential process, right? It's always trying to jump out of the box. And so you can never let the pressure off. I just put here at the bottom, I didn't graph prevalence because I thought I would put you to sleep with so many graphs, but HIV prevalence, if the disruption is kept to just a few months, you really don't see a noticeable difference in HIV prevalence out in the 2040s, 2050s, 2060s. But in this unabated scenario, we could see a doubling or a tripling of HIV prevalence. And something really striking, which you'll see on the next slide in a moment, is for children, you can see HIV prevalence go up by we found 40-fold, just a huge resurgence in HIV prevalence because vertical transmission is really reliant on the stability of these programs. So let's talk a little bit about subpopulation stratification. This is a lot of numbers on the screen, so I'll just tell you the broad message. With a disruption to PEPFAR, by the numbers, the most burden is felt by women, because women have the most HIV. There are the most people with HIV are women in this region. And so just numerically, you see the most deaths, you see the most additional infections, and you see the most additional people who will be still living with HIV out in the distant future among women. But proportionally, in terms of how much worse did it get relative to where it was before, by far the worst outcome is children. So if you go home with anything, go home with the message that who this is hurting the most is women and children. You can tell that to the press. And so we can start going through these numbers now and unpacking a little bit. So here we see a 3-month, 1-year, 4-year, and unabated disruption. So how long the disruption lasts. And we can look at the effect of that on additional deaths, additional acquisitions, or people becoming HIV positive. And then there was one other interesting thing that we looked at, which is how many additional person years will need to be on HIV treatment in the long run, all the way through the 2050s. And this is going through 2055, so this is a 30-year time horizon. If you disrupt HIV care today, will we, in the long run, end up treating more people or less people? That was kind of another interesting question that we asked. This goes to the health economists who are thinking about budget impact as well. Yes. Did you have a question?
No, we'll ask at the end.
Okay, great. So we already kind of know this story. The additional deaths, numerically, you'll see the highest numbers in women, and we already went through some of these numbers. But in terms of percentage increase, you'll see the highest percent increase in children. So from a 4-year disruption, you'll see over a 300%, so a quadrupling of HIV deaths in children. And it's like a 2,000% increase if in an unabated scenario, because we really were on track to elimination of mother-to-child transmission. In terms of additional HIV acquisitions, very similar story. You'll see more additional acquisitions by the numbers in women, but the largest percent increase in children. And then the additional person years on treatment is kind of an interesting one, because if you stop delivering HIV treatment, you will have fewer, indefinitely, of course, you'll have fewer person years on treatment. And so in this unabated scenario, you see fair decreases of about 40% in adults and about 200% in children. About a 40% decrease in adults. You actually see a 200% increase in children because you get a surge of kids with HIV. So those people do end up getting more treatment even in the absence of PEPFAR. And then in terms of if these disruptions were curtailed, you actually see pretty small numbers. So it's kind of within a couple of percent, meaning that if you stop PEPFAR for a few years and then you start it again, all the treatment you didn't deliver while you were stopping PEPFAR, you end up having to deliver more treatment later because all of the people who have gotten HIV infections. So it kind of evens out in the long term in terms of the number of person years that will need to be on treatment. But it's a much worse scenario, of course, with more deaths. In children, once again, even if the disruption is relatively short, you end up having to do a lot more treatment. So with a 4-year disruption, for example, you have more than a doubling of the number of kids who will need treatment over the next 30 years because you have this surge in children, and then they're going to need treatment for life. And then I know many of you are thinking I'm being very specific with my responses, but if we were there in January with a lot of uncertainty about what would happen, and we were making very simplistic assumptions, like either there's a disruption or there's no disruption. We weren't really thinking about all the in-betweens of if there's some partial funding restoration, if the government takes greater responsibility, if there's adaptation. And so in that very simplistic sense, we wanted to just show the magnitude of the uncertainty that we had. So with the Ministry of Health, we invited them to give us a range of like, this is the lowest possible and this is the highest possible effect size that we might be seeing. So for example, in terms of treatment attrition, annual treatment attrition, we assumed in our base case that it went to 20% based on the evidence that we had from the 2010s, that was what treatment attrition looked like before appointment systems and defaulter tracing. But that attrition per year might have been only 10%, or it might have been as high as 30%, because it was a very different circumstance than the mid-2010s. And so you can see that actually the effect of the PEPFAR disruptions on attrition was the most sensitive thing. It was the thing we would have needed to know the most precisely to make our estimates more accurate because it had the largest effect on our overall estimates. So we could have been wrong by about 20 to 30% on deaths, and again, by about 10 to 30% on infections. And again, by about 30% in terms of additional person years on ART, just based on our uncertainty in terms of attrition. So it's interesting that was the assumption that our model was the most sensitive to. We also looked at, in the 5 provinces in the northern half of Zambia, we knew that 40% of clinics had USAID frontline workers, but there were also government employees in those clinics. Now, those government employees are very busy. It's hard when someone is stretched to the limit to ask them to do much more. But there's still uncertainty about, maybe the withdrawal of those staff could have been backfilled to some extent by the government, or maybe actually the withdrawal of those staff could have had cascading effects. So it was, we assumed 40%, but it was actually 70% of clinics that had some USAID presence. So we looked at a worst case scenario where all 70% of clients now can't get treatment because they were part of a clinic that had a USAID employee, which is that's like a way, very depressing bound. Or you could assume maybe only 10% of people lost access to treatment because it really would only affect someone if the clinic was almost exclusively run by USAID. And so there's the uncertainty there. And it's very interesting because I would have guessed that this assumption would have really driven our analysis because we're talking about like pulling nurses out of the field. But actually our analysis was less sensitive to this assumption than it was to the effect on attrition. So it's really maintaining the defaulter tracing, maintaining the appointment systems, the use-friendly services. That was really key to keeping a cap on HIV during this time. So even if we varied the reduction in access, which we had assumed was 40%, between 10 and 70%, which is a really wide range, it would still have a relatively small effect. It might have changed our answer by 10 to 20%. It had a bigger effect on person years on ART, but again, 20 to 25% uncertainty. And then finally, we looked at our assumptions regarding VMMC and PrEP. And we couldn't get any more pessimistic. We just assumed that all PrEP would stop except for pregnant and lactating women, and we assumed that all VMMC would stop, and that assumption so far has basically proven true. There's not a lot of PrEP continuation, and there's, as far as I know, no subsidized male circumcision program in Zambia, which is quite sad. But actually, you could see that had very little impact on deaths, even over our long time horizon. It had a pretty substantial impact on our projections of new infections. So here we're assuming, what if there was a 50 or an 80% reduction instead of a 100% reduction? That uncertainty would have had a pretty big effect, but not as big an effect as the attrition uncertainty. And then it had a pretty small effect on treatment, person years on treatment. So this was sort of the best that we could do in the absence of data, and I think even still, it's really hard to go and look at exactly what was going on for the past few months because data systems were down. So I think if you take one message from this, it's of all of the things that you need to try to keep under control when funding is pulled out, the most important thing is treatment attrition, preventing treatment attrition. It seems like that's been a big driver of treatment as prevention. Okay, so what can be done? I'll state the obvious first. You should limit the duration of disruptions to less than 3 months, because doing so would limit excess infections to only 13%, only a 13% increase, I say that in quotes, and excess deaths to quote unquote only 8.7%. And the long-term prevalence of HIV, if it were limited to 3 months, would not change, so 0.0 fold difference over 20 years. But I think even more importantly, what needs to be done is to deploy strategies to overcome commodity gaps, to overcome overburdened human resources when suddenly these extra resources have been taken away. So what are some examples of what could be done here? We've been talking a lot about HIV testing in the other room. HIV self-tests are one way to take some burden off of staff. In general, when HIV testing services are available, the so-called yield, or the percent of people who test who are positive, is pretty low, a couple of percent nowadays. And so if people could self-test, and then only those who self-test positive would be triaged into further counseling and care, that could, unburden staff by a factor of 50 in terms of the time that they might have. Currently, the World Health Organization already recommends facility-based HIV self-testing to reduce the burden on staff. And also something that did happen in Zambia, actually, you may have heard on the news the past couple of days of, in America, they've discovered warehouses full of contraceptive products, medications, food, things like biscuits for moderate malnutrition in children that are expiring because the staff who were supposed to move them were fired. And so in these circumstances, this also affected HIV testing, and so there have been stockouts of the Determine, the first test that's used to screen people for HIV, and thankfully there were HIV self-tests in the country that could be used to quickly backfill those stockouts. So the WHO now officially supports this strategy as well. So having self-tests there as a backup plan in case your regular tests stock out, and using it to triage people. And I'm just harping on HIV self-testing because it's one technology that's right there in front of us that could quickly strengthen health systems. There are opportunities to grow HIV self-testing in communities. We've been talking a little bit about community health workers and community testing in the private sector, private pharmacies, digital health applications, workplaces that could do HIV screening. And then also, PrEP is really under fire right now. Due to the lack of resources, PrEP generally compared to treatment ranks as less cost effective. But to the extent that PrEP does continue, HIV self-testing so that clients don't have to keep returning to clinic to keep being rescreened to ensure they're HIV negative, dispensing PrEP with HIV self-testing could be another way to make all of these programs more sustainable. So I just want to leave you with a few key messages. One is that funding disruptions can reverse progress toward HIV control in Zambia. And if the disruptions persist for a year or more, the resurgence that will happen will persist for decades, even if the services come back. Women and children will bear the brunt of the disruptions in terms of additional HIV infections and HIV-related deaths. And tools and strategies are needed to enhance the reliability and efficiency of HIV services. So we talked a little bit about how self-testing can help backfill stockouts, reduce costs, and reduce burden on human resources. But we need similar strategies to those for ART. So something I'm personally very passionate about, if anyone here is interested in this, is what's the equivalent of an HIV self-test for ART? How do we vastly reduce the cost of ART delivery and make it very robust, so that it's not so dependent on the health system being functional, as well as male circumcision, PrEP, condom delivery, and all of these other program components, right? We need to use the resources in the country, oftentimes the communities themselves, to make these a lot less costly to deliver so they can be sustained. Thank you very much. I'm right on time.
Thank you very much, Anna. That shows that decisions which are made in the boardroom can be costly.
Yeah.
So I don't want to take your limelight. Before we proceed, I just want to know we have got some guests here. The director of the Research Support Center who is hosting us this can introduce the guests who have come. And I will, because in Malawi we are very famous in hospitable. We are home heart of Africa. So we always recognize guests. So can you introduce the guests, then I'll introduce my guests too.
Okay.
Yes.
I think I'll also ask my guests to introduce themselves.
Yes, yes.
But just to say that this week we had been privileged to host Stellenbosch University.
Cool.
So our visitors are coming from Stellenbosch. We've been working with them. They are mentoring the Research Support Office.
Okay.
So this is an exchange visit. We had a team of KUHeS staff who went end of June, and now they came to visit us. It has been a wonderful week. We've enjoyed everything. So we say, when we heard you had organized this seminar, we had said to them that seminars are some of the things that we host in this department. So this was a timely arrangement, and we are happy that they were able to be with us. So I'll ask you to introduce yourself.
Sure. I am the Dean Professor. I am the Manager for Research Information and Strategy, and I form part of the Cluster for Research Information and Strategy, the Division of Research Development at Stellenbosch University.
Good afternoon, everyone. My name is KUHeS. I'm the Director for Emerging Scholar Funding and Support, and I work with my colleague in the Division of Research. I don't think there's anyone else.
Out?
No, within the department.
Yeah, they've got sessions on at the moment.
Oh, they have sessions, okay. But otherwise we had 6 of them visiting. So this was a great privilege, and we've benefited from your great presentation. Things that we take for granted. So when we heard that Trump had made these directives, we never thought it would have this great impact on the work that we're doing. So thank you for sharing, for the insights that you've shared today. Thank you so much.
Thank you. So, again, I would like, for those who are new, here we have got Professor Anna Bershteyn, Professor of Population Health Studies, a modeler, and also worked as a funder with Gates when she was leading as the director for the Disease Modeling Institute in Seattle. So we have got a very, very important person. Now it's a time of questions and answers. So now I'll push, yes, HOD, you are reading, you are there, HOD, and you'll be the first one to, that's fine.
No, thank you. I'm just a thank you very much, Prof. No, thank you very much, Prof. This is very insightful and interesting presentations. I've got several questions, but I'll start with 2. So, no, I'll ask 2 then I'll let the others ask. If there is time, I'll ask the other ones. So I'm not selfish. But I was interested in your assumptions. I mean, the tests that are happening here are disheartening. So I'm interested to understand more about the assumptions you made about impact of these cuts on quality of care and adherence, because these are the pathways to mortality. I just want to understand how you dealt with these in your modeling.
Yeah, so it's going to be very nuanced, right? Because some of the support that was lost was technical assistance, things that the effect sizes between some of the ways that PEPFAR was supporting the Zambian HIV program and outcomes have not been rigorously measured. So we leaned on the expertise of the MOH, and they, as you saw, they benchmark their assumptions based on where in our country does USAID have a frontline care delivery role, and where do they have a little bit more of a systems role, things like supply chains, things like specimen couriering, IT, and digital like EHR systems. And so based on that, they said, okay, we want you to model these provinces with cataclysmic effects, and then we want you to model provinces where it's not so much that care is stopping, but it's taking us back to where we were 10 years ago. And so we did those two things, and it was actually surprising to us that the fact that somebody's nurse that they depended on being there was fired was not as big an effect as the fact that they were going back 10 years in terms of maintaining people in care. It's easy to forget how far these systems have come, in terms of client-centered care that people are willing to stay in for long periods of time.
Okay. And do we know, or do you know how the ministry has responded to this policy-wise? For example, to mobilize resources to try to fill the gap. I mean, you've suggested suggestions on how to cope with the shock, but I don't know if there are primary responses actually to fill the shock by mobilizing resources or reprogram resources based on your work.
So the prevention, as far as I know, they've let go. So they've not attempted to restore male circumcision or PrEP, other than PrEP for pregnant and lactating women. In terms of the care continuum, kind of the emergency response had been, let's just move drug to clinics and let's just dispense. We don't have access to the charts. We are not going to be able to do detailed counseling, but let's just make sure people who want drugs can get those drugs in hand. And then it was a dance of supply. So fortunately, first-line medications, there was something that happened pretty quickly afterward was a waiver that allowed at least the first-line medications to flow, and that meant that clinics could go back to dispensing 6 months of medication at a time instead of 1 month, which is what they did when everything froze. And so, it would be so interesting to go back and do a post-mortem, because I was just in Zambia and I don't see people with AIDS walking around. Transmission can be quite silent, but AIDS is not silent. And I think that people were probably educated enough. They knew what their medication looked like, and they were just able to find some place that could dispense medication to them. And to me, that was why, I talk about self-testing, because there are new WHO guidelines that say, give people self-tests and trust them to do the right thing. But we don't do that with treatment right now. And I think it would be fascinating to go and do a post-mortem on what happened in Zambia as the hardest hit country and see what we can learn in terms of making HIV care sustainable by trusting people, to do the right thing. And, even without all of the TA and all of the labs and everything, that a lot of people actually can do okay, as long as they can find someone who's willing to hand them their medication.
Thank you very much.
Yeah.
I think to link onto that, I think the big concern here is you've said that people that have been in treatment, they know what to do. I think the big issue here is new infections. Those people do not know necessarily to which route to follow, medication to take, etc. If they even know, even if they're infected.
Yeah, precisely. Those people, and then youth are the other population that even if they know what to do, they're not necessarily going to do it. So it's one of the real tragedies is that many programs, there was a lot of foreign support for programs for key populations and youth, so-called youth-friendly services. So these could be bespoke clinics that are kind of decorated with cool, hip decor, and they're for youth, or clinics having youth days, right, where they don't have to sit next to the grandmothers and they can kind of be with their peers. And so a lot of that has stopped. And even we're part of a network of RCTs, because there's still actually not the greatest evidence on what is the best way to get youth engaged. And so there's a network called Inspire of implementation studies, and like half of the studies were stopped too. So it's, I think the field was kind of going in the right direction. And I'll even say when Trump was elected, there was a conservative playbook that had been published even before the election called Project 2025. And it stipulated that PEPFAR should wind down. I think it wanted PEPFAR to decline by about 50% over the course of the presidential administration, so over 4 years. And I work a lot in the HIV community. I was just at the International AIDS Society conference. And I think that the community understood that there is a certain degree of HIV exceptionalism. The generosity of other countries you can't rely on that indefinitely. And the community was on board to say, all right, we're going to, over 4 years, we're going to offload half of the responsibility from this program to governments. But what happened here was not that, right? I think if things had gone according to plan, really the resources that were coming in could have been focused on these populations that we're still not sure what is the best way to reach, or that governments have a hard time politically having bespoke sexual minority programming, right, given the context in some of these countries. But they never had the opportunity to systematically wind down PEPFAR. And so this is sort of the worst possible scenario.
Is that
Maybe two issues. The first one is I don't know if you have any plans to continue with the study, like maybe doing it in other areas, or maybe consider doing a qualitative study just to understand, emotions and all these other things that qualitative study will not be able to capture. Then the other thing that I wanted to just understand is from your your experience and what you've seen. Because here we struggle because most of our funds normally come from the north. But now with the geopolitics coming in, obviously whether we like it or not, these issues will still be happening. And that will prevent us to be able to attract funding, because then there will be some areas where there will be some restrictions and so on and so forth. So I just wanted to understand to what extent do other universities from where you're probably coming from able to have funding from other areas where maybe some of these things may not be able to affect, because now you can actually see that diversity is becoming important now. To be able to find different funders for different things that we are trying to do. And then also, yes, that's what I wanted to understand from your experiences.
Yeah, so PEPFAR has been a huge funder for HIV. The most recent budget that has been passed did restore PEPFAR funding partially. So I think there is still commitment in America to continue funding, but I absolutely agree. I hope it doesn't collapse like it did, but it will steadily decline. And so the diversification of funding, I think sweating the costs out of delivery. So it's not really talked about, but about half of PEPFAR funding is used to pay Americans. Yeah. It's spent in Washington, D.C. at the PEPFAR offices. It's spent on Americans doing technical assistance in Africa. And so, that's a lot of money that could be maybe sweated out of the program if it could be systematized or absorbed into governments or just done more cheaply. And then even delivery, is there some way to deliver treatment? One study that I thought would be fascinating to do, I'd love to hear from the health economists, is if you did kind of a interactive knapsack problem. So if you said, okay, this bag is your budget, right? And this brick is the cost of buying the drugs, and this brick is the cost of doing a viral load, which, by the way, is as big as the cost of a year of drugs. And this is your technical assistance, your supply chain, your monitoring, your this, and this bag is your budget. You can't fit any more in the bag. Here's a world with a bigger bag, here's a world with a smaller bag. How are you going to pick and choose? And is it possible to get care to work? Can we creatively get care to somehow work with the smaller bag, at least for some population segments, which is going to be a growing population segment. So that kind of thing, integration is part of sweating the costs out of HIV care. The other piece, you talked about qualitative research, and that I don't see someone doing that research. That could be something, maybe an area for collaboration, is going back and doing that post-mortem, talking to clients and saying, hey, PEPFAR collapsed. How did you get your medication? How did you care for yourself? Was it working for you? How did you feel just having medications kind of blindly dispensed versus having a provider that you see, and trying to learn from that, maybe something about sustainability. Yeah.
question? Online? Any questions online? Okay, that means no.
Yes.
One more. So one thing that struck me about this model is that it picked the increase in death almost immediately. And I would have thought that, I can understand it picking incidence almost immediately, but I would have thought death would lag.
Yeah, and that is what we saw.
The conditions have to come in first before we start people dying, but we see
Yeah,
almost an immediate uptake. So I wanted to understand
yeah.
from your...
It's a great question. So if this is incidence, you can see as soon as action happens, it goes straight up. And this is mortality. So it is much more gradual. So there are some people who, 1 year after the disruption, you will see some increment in mortality. Those in our model tend to be old people, will be athymic, and they have a really hard time maintaining latency and replenishing all those T cells that the virus is destroying. And then you see that mounting mortality over time. The people who are maybe a bit healthier, a bit younger when they interrupted care, who could live longer until they see mortality.
Yeah, but the disruption is happening midway about 2025.
Yeah.
Already speaking,
Yeah, so here's 2025, and you can see there's just a small increment compared to the peak, whereas incidence, here's 2025 and yes.
Have you modeled the impact, the difference of impact between commodity interruption versus the system?
We have not. We've not modeled what system is most critical.
No, I'm just talking about the means to deliver it.
Yeah.
So because it will be also very interesting because, as you have said, that for commodities, that is the funding has been restored to a certain extent, isn't it, or not?
Yeah, but as the media reported just this week, some of those commodities have expired in warehouses in America. Food aid, like these nutritional biscuits, contraception, they sat in a warehouse and they're going to be destroyed because they fired the people who were responsible for arranging the shipments.
Yeah, but it would be really nice to look at, because sometimes we just look at commodities if we don't see the impact of the systems.
Right. Yeah, but they're very intertwined, right? If the system can't move the commodities, they still won't get to where they need to go, unfortunately, as we're seeing right now. It's a bit of a scandal. We should all be on social media about it to make it a bigger scandal. Yeah.
So maybe just for the interest of others, I'm sure people normally when we're done these seminars, they will knock on my door asking for information on some of the things that we presented. So I don't know, with your permission, can I share the slides?
Yeah, absolutely. And the paper should be out, yes.
So colleagues, you can email me at ric.coordination@KUHeS.ac.mw and I can share the slides. I'm pretty sure people will be interested to see whether you can replicate a similar study in Malawi. It will be interesting just to see the issues. Yeah.
And I'll say we do have a paper should be coming out soon, and what I'm really proud of in that paper is the first 12 authors are Zambian. We have 3 permanent secretaries as co-authors on the paper, so that's like the best thing about it, is that it was really, as modelers, we were just absorbing the information and turning it into graphs, but it was really Zambian led. So we would love to do that here. That would be really cool. Thank you.
Clap our hands for Anna. So thank you. Sorry, we had to go to time, but I would have stayed here because it affects Malawi. I think I will tell the people because we are given the same, but at the speed, the way you responded and you came with your publication was amazing. I think it was the first group of the modelers who were able to come and show what is the impact of, and I think we have done a great job to open our eyes. And it's very scary. If you look at this graph, when I look at it, I just fear that you can, almost like you have cut a leg of somebody, you cannot almost reverse. So we need to advocate and speak about this. Very much.
But ultimately, it pushes us to start thinking of solutions. I remember 2005, a Department of Science, Medical Science in the US, asked me to be one of the reviewers for the document, post-document from the US on shared responsibility on HIV, where they were looking at the possibility of cut of aid by another American government. They were already seeing that there was possibility that somebody will come in the boardroom or do something like this.
Yeah.
And that document was shared, published in 2005. But countries haven't. So now we have this shock, which is just come 20 years after. So I just wanted to say that we need to start thinking about solutions.
Can I make a comment on that,
Yes,
actually?
yes.
This is a project that I had going on with Paul Revel, who's here often. Health economic analysis, we have a counterfactual. And our counterfactual is often maintain status quo indefinitely. But that is not the world that we live in. You know, climate change, conflict, pandemics, it's all becoming more frequent. This earth is getting more crowded, and the atmosphere is getting more full of CO2, and it's not always realistic to think that what we have today we will have without any disruption for 50 years. And so something that we are exploring in one project is the health system you build to have the most benefit to your population compared to continuing the status quo. Is it different from the health system you would build today if sometime in the next 50 years you had some cataclysmic event? So we tend not to prioritize primary HIV prevention. Sorry, I have my back to you. We tend not to prioritize PrEP and things like that because it's less cost effective compared to a stable counterfactual. But primary prevention might look a lot better. You know, it's much better just never to have HIV at all than to depend on the health system for treatment. And so how does that cost effectiveness prioritization get scrambled depending on how bad the future is for climate change and everything else? It's maybe another area we could work together on. Yeah.
So with this, I would like to thank also Director of the Research Support Center for co-organizing this and availing this space, and also for the guests, bringing them. You are not being selfish. When there's a meal, you don't want to eat alone. You invite the guests to come. And I would like also to thank the HOD here, FCT, who has come and they also asked questions. And everybody who came. We value your presence and especially your vision to understand this is very important. What I've learned here that there are two types of model, compartmental and individual model. That's what I've taken. And I've taken also that this is going to have. For me, I didn't understand that. I didn't think that the impact is so immense. But when you presented, I was shocked. And I think that shock therapy will push me to start thinking about solutions. I hope everybody has taken something. And we don't have time, but I think there's a lot we can share about what we can do at all. Thank you very much. Have a nice day. Enjoy. There's the music there. You can go and just enjoy.